Good afternoon, good evening, everybody. My name is Sandra Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome to this public health conversation. These public health conversations are meant as spaces where we come together to address the ideas that shape a healthier world. Through a process of conversation and debate, we sharpen our thinking, guided by experts. In doing so, we aim to advance the conversations that shape a healthier world. Thank you for joining us for today's event. Thank you to the many who work to make today happen, in particular the Dean's Office and our marketing communications team. Today is the fourth installment of our Teaching Public Health series. We began this series in 2018 to advance the public health pedagogy that helps create the next generation of leaders in our field. Today, we're going to discuss the central importance of writing and communication to this work. In public health, we are tasked with speaking to a range of constituencies, from the public to the media to policymakers. Doing so effectively is core to our mission of creating healthy populations, and yet one cannot help feeling that we pay less attention to this in our teaching than we should. During COVID, communication played a key role in our response to the pandemic. Our successes and failures during those years can help inform our reflections now, helping us to become better communicators and to transmit these skills to our students. It can also perhaps help us redouble our effort towards engaging with teaching better writing and communication in our schools and programs. It's really a pleasure to be here with you all, and I'm looking forward to learning from all our speakers. It's now my great privilege to turn the screen over to the intellectual architect of the symposium, our Associate Dean for Education, Dean Lisa Sullivan. Dean Sullivan will introduce the speakers and moderate the conversation. Dean Sullivan.
Thank you. Thank you so much for that kind introduction. It is an honor to be here today to moderate today's discussion on writing and communication and how central communication is to effective public health. First, I will introduce the panel, and once all of the speakers have presented, we'll have a moderated Q&A session. Please submit your questions through the Q&A feature on Zoom, and panelists, please refrain from answering the questions as they pop up, as we'll save those for the Q&A. Our first speaker today is Dr. Jennifer Beard, Clinical Associate Professor in the Department of Global Health at the Boston University School of Public Health. She is also the Associate Editor of Public Health Post and an Assistant Director for Narrative in the Center for Anti-Racist Research. She teaches courses in global mental health storytelling, and public health writing. Dr. Beard founded the BU Program for Global Health Storytelling, a collaboration between BU SPH, the BU College of Communication, and the Pulitzer Center. She is also a BU SPH alum. Next, we'll hear from Ms. Rosanna Kaczmarczyk, Vice President of Social Impact at Syneos Health. She has more than 14 years of experience in health communications with a focus in environmental, social, and governance. She has worked with partners across the public, private, and nonprofit sectors to develop events and campaigns that educate and drive health action among consumers as well as health decision makers. Ms. Kaczmarczyk is also a proud BU SPH alum. Then we will turn to Ms. Ashley King, Health Communication Manager at Communicate Health. She has experience that spans across university, nonprofit, community, and local government health programming and research. Ms. King brings a unique perspective and expertise to the field. She is passionate about starting new and meaningful conversations about health, using her extensive background in adolescent health research, health communication, and health promotion. Ms. King is also a proud BU SPH alum. Next, we will hear from Dr. Sarah McKenzie, a family physician, public health practitioner, curriculum developer, author, and teaching professor emeritus. She has served as Assistant Dean for Undergraduate Education and founded the University of Washington Public Health Global Health degree program. She strongly believes that writing is a critical skill set for public health professionals, and that intentional integration of writing into and across programs is essential for building equitable curricula that provide students with the skills they need to be successful. We will then turn to Dr. Xiaoli Nan, distinguished scholar, teacher, and professor of communication at the University of Maryland, College Park. Dr. Nan is the director of the University of Maryland Center for Health and Risk Communication and has been a senior editor for the journal Health Communication since 2018. Dr. Nan's recent work has addressed COVID-19 public health communication, health misinformation, and the impact of morality on health beliefs and behaviors. In 2020, Dr. Nan was named the Lewis Donahue Outstanding Health Communication Scholar at the Kentucky Conference on Health Communication. Lastly, we will hear from Dr. Kazizomayajula Viswana, the Lee Kum-Kee Professor of Health Communication in the Department of Social and Behavioral Sciences at the Harvard T.H. Chan School of Public Health. Dr. Vish's work draws from literatures in communication science, social epidemiology, and social and health behavior sciences, and focuses on translational communication science to influence public health policy and practice. His primary research is in documenting the relationship between communication inequalities, poverty, health disparities, and knowledge translation to address health disparities. Thank you all for joining us today. I'll now turn it over to Jen Beard.
Thank you so much, Lisa and Dean Galea. I'm really, really delighted to be here. And I've been excited about this event since we started thinking about it. So I am going to share some slides. Okay, so the title of my talk today is Public Health Writing Across the Life Course. Excuse me, but I couldn't actually decide between two different titles. So my alternative title is Public Health Professors Are Writing Mentors. And I apologize. I hope that you will see why as I sort of progress through my story. So I want to start out with a quote, and the quote is, "Writing is public health. It is what makes public health public. It's the way that we in public health convey our messages, policies, and practices, and it's the way that we prompt action." So in other words, it's everything. So now I'd like to tell you a little bit of a story. So when I was an undergraduate English major, I clearly remember the feeling of having lost control of my writing. I had so many words and ideas, and for the life of me, I could no longer remember how to construct a sentence or use a comma. This happened sometime around my junior year. Before that, in high school, and my first couple of years of college, writing had come fairly easily, and I'll admit that I didn't try very hard, but my papers were generally satisfactory, if not brilliant. Then a couple of things happened. I started getting excited about the Elizabeth Gaskell novels I was reading about industrialized Victorian England. I was inspired, really inspired for the first time by several professors who encouraged me to peer into the past and the present through these teeming fictional worlds. And every time I sat down to write, my ideas, words, and sentences started colliding into one another, splintering off in new directions and reaching beyond what I was easily able to articulate. I'm sure those papers were very challenging to read for my professors. I'm grateful that they were patient and generous readers. They apparently saw the ideas and gave me the benefit of the doubt. And they mentored me through the process of regaining my ability to write a coherent sentence. So they didn't let me off the hook. They made me work. And at the end of the process, I was able to write coherent sentences again with more or less correct punctuation and work through the all the time jumble of ideas in my head. So the process, it was slow and it was awkward, but I eventually got back on track. I started my master's degree in English literature and eventually completed my PhD. I taught freshman composition throughout graduate school. I learned about the writing process, about writing as a form of learning, about the connection between writing and cognitive development and language acquisition. I was able to look back at my sentence structure meltdown and see it in a new light. My abstract thinking had outpaced my ability to clearly formulate thoughts and information on the page. But with time, patience, and patient professors, I caught up. Then I decided to enroll in the MPH program here at BUSPH, and it happened all over again. This time, I wasn't floundering at the sentence level. Instead, I was bogged down in a sea of technical language and numbers, writing documents I'd never heard of before. Hello, policy brief and research memo. This time, the emotional stakes were much higher. I had a PhD in English, for goodness sake, and I had been an editor and a writing teacher. Now I was writing papers about HIV in Ghana and forgetting, or maybe not even realizing, that I needed to mention that 2% of the adult population was HIV positive. It could have been demoralizing, and sometimes it certainly was. But again, patient professors and my previous experience helped me to get back on track again, to feel optimistic that with time and with feedback and the opportunity to revise and revise again, that I would eventually figure out how to write that satisfactory policy brief or literature review or whatever. Most of our students are on similar journeys, and the same is true for us, their professors, obviously. Many of us spend our lives sliding back and forth on an emotional continuum of writing confidence and panic. And so for me, that continuum looks like this. It's a simple arrow, and on one end, we've got hopelessness. On the other end, we've got brilliance, and in the middle, we're all sort of bumbling about back and forth, sometimes in the space of 1 hour between the two extremes, or at least this is true for me. So we can't assume that our students know how to write public health documents when they get to our classes. They come from so many different types of backgrounds. They're English majors, they're political science majors. Some of them are doctors. Some of them have never written a paper. Some of them have no idea how to cite a source. Yet we often do assume that they know not only how to write and to write clearly, but they know how to write a policy brief, and they even know what one is. So that is that's just it's sort of delusional thinking, and it's something that I think we all need to get over, and we need to expect to mentor our students. Yet we often lack the personal confidence, the time, and the institutional support to give them feedback on multiple drafts. And I would say that this is particularly true, or it seems to me to be particularly true at the graduate level. All of my students are graduate students, so they come from so many different backgrounds, and we just assume they learned how to write when they were in high school and undergrads. But it's the type of writing we're asking them to do is not the same. It's not the same at all. So writing across the life course has been really helpful for me in terms of how I think about my writing, my students' writing, and how to sort of help them go through the process. So, you know, when we think about the life course and putting the writer into it, every writer is influenced by individual and contextual factors over time. That the life course approach helps us reimagine our relationship with our writing as we build our knowledge, as we learn new skills, accumulate experience and feedback, and develop our sense of identity as a writer. So some of the things that we think about when we're talking about the life course in this list, some of these are typical, the things you'd expect to see when you're talking about the life course and public health, and some of them are specific to writing. So we've got the interplay of human lives, of writing experience and context. We've got the social determinants that influence our trajectory, the trajectory of our writing experience and of our attitudes and thoughts about ourselves as a writer. Were we encouraged? Were we not? Did somebody hold us to account and make us work hard? Those things are all important. And then we've got the sort of pathways, transitions, and turning points. And I hope that my story illuminated some of those things. And then from the perspective of writing and what we need when we are trying to develop our skills, we need interpersonal mentoring. We need feedback. We need to understand that we have a writing process. Even if you don't think you do, you do. And sort of figuring out what that is and how you can build it and revise it is important, as is developing a deliberate writing practice, where you know that your first draft is not going to be perfect and your second draft isn't either. And you set out to do specific things like, I'm going to try and make sure that all of the subjects and verbs of my sentences are clear. And if I do nothing else, that will actually help improve the clarity of my writing. So my fellow panelist, Sarah McKenzie, wrote a paper and published it in Public Health Reports in 2018 that's been really, really helpful to me and to my thinking. And she urges us to ask two questions. So the first one is, how and when did we learn, we public health professors, how to write public health documents? How did we learn to do the writing that we do for our jobs? And what are we trying to achieve when we assign a writing project in our classes? There's so many different things that we are trying to get students to do. We want them to bring in evidence. We want them to build an argument. We want them to write for a specific audience. And so just very briefly, the social ecological model, I think, is a really helpful way of thinking about these things. So we've got individual writers and interpersonal mentoring here at the center of the concentric circles. And we need to expand beyond that because there's an enormous amount of pressure that is put on both professors and students when we only focus at that level. We really need to build institutional support. So here at BUSPH, we have started to do that. We have a public health writing program where we have built a number of resources for students to help them take responsibility for developing their deliberate practice and for trying to become better writers. And one of the most important parts of that, the most important part of that, is our peer writing coach program, where public health students who are 1 or 2 semesters into the program are available, have been trained and are available to provide feedback to students. We also have a much more intensive public health writing apprenticeship through Public Health Post. And I encourage you to take a look at Public Health Post to see what our student writers are doing there. And I will just end by letting you know that I just wrote a book called Teaching Public Health Writing, where I try to apply a lot of the things that we think about, a lot of the concepts that we use in public health to writing. So the social ecological model, social determinants of health, harm reduction, etc. So I will end there and turn it back over to Lisa. Thank you so much.
Thank you, Jen, and thank you for your humility. It's reassuring for those of us who are less well-trained than you, so thank you for that. Next, we will hear from Rosanna Kaczmarczyk. Take it away.
Hey everyone, let me just get my screen up there. Yeah, everyone can see it. So take a moment to thank everyone for inviting me to be a part of this panel and to be here among such other esteemed panelists. I graduated from BU School of Public Health many years ago, and quite honestly, when I took my first job in health communications at a PR firm, I was really one of 2 MPHs who was employed there. So this panel gives me a lot of hope that there's more MPHs coming down the line who are interested in this and really will help everyone have more effective health messages out there. So I'm really excited to be a part of this. And please bear with me, I have a little cold, so I apologize for the scratchy throat. But just wanted to start for a second. You know, we're all bombarded by information. There's a lot of information out there. There's no surprise for anyone who's on this call for that. I'm not going to take offense, but there's probably a couple out there, people watching who are scanning your phone while you're listening to me talk. Maybe you're checking on your kid's daycare app or your doggy daycare updates or the status of your lunch delivery. No judgment, but I'll try to keep your attention. So when we're thinking about actual health messages, what makes a message stick? And this really goes for any message, but it also includes those around health. So we want our messages to be brief. We want them to convey something that we want people to do. They should be tailored to those who want to hear it. They should be relatively simple to grasp and evoke emotion. And they also should come from voices where the intended audience trusts them. They should be repeated across channels to increase the likelihood that someone in our audience will hear it. And they should ideally be seen multiple times. So whether that's in television or streaming, radio and podcasts, social media feeds, billboards, sides of buses, all of the above, some of those. And to that end, you should know where the people you want to reach are going for that information. So the mix of places where you want to reach them could change for different audiences. So with that in mind, I'd like to take us back and keep this back to COVID-19 as our reference. So one of the good things about being in a global pandemic particularly in hindsight, is that, especially one that was one of its kind for the whole world's population, is that in theory, this should make our message around it sticky. And in March of 2020, that was pretty much the case, I would say. COVID certainly induced a lot of emotions for people and made them pay attention. The message around it was pretty ubiquitous. The call to actions, for the most part, were pretty simple in the beginning. Important voices and leaders were driving the message. The degree of trust there did vary, but it was pretty high in the beginning. Because we were all aligned to the same simple actions that we had to take, particularly in the very beginning, the messages were really tailored to all of us. And for the most part, they were easy to understand. And they were really the main thing we heard across a lot of channels. So they were getting out there and they were getting in front of us. But 2 years later, I think we all know that COVID-19 was not the most smashing success in terms of messages and related health outcomes. So I thought maybe there was a lot of messages around TEVA around COVID that we needed to get across. So, that ranged from masking to vaccinations to quarantines. So for the purposes of the short time I have with you all today, I thought we could take a deeper look at one set of COVID messages around masking and see what we could learn from it. So here is a quick sample of some of the messages that we saw around masking throughout the COVID-19 pandemic. This is the sample, they're paraphrased, but just really to remind us of the evolution. Maybe this takes you back to when you were learning how to sew masks at home or scouring on Etsy, looking to find that, perfect color one that could match your outfit that you're on Zoom calls for. Or maybe that exciting moment when you put your cloth masks aside and you could finally find a bulk box of surgical masks, or better yet, N95s, and you really felt like you were being protected. But the message really did change quite a bit, and it wasn't a linear progression, as with many things we saw with COVID. So we went from no masks to any type of mask was needed everywhere, to different types of recommendations about the strength of masks and what people should be wearing, to a hopeful message of lessen mask wearing if you had been vaccinated, to a stronger need for masks, even if you were vaccinated as the variants emerged, to I think where we kind of are today, where it's been nearly 2.5 years, most people who want to be vaccinated can, so it's up to you. So individually, when we think back to what makes a message sticky, any of these were, in some cases, sticky, but collectively, the evolution of these messages and others around COVID is what made them tricky. So when we look to what made them tricky, I think there's a couple of things that I zeroed in on that really kind of resonated for me. So I think at the core of it is people really didn't understand how much these messages would evolve. They didn't realize how quickly science would shift and uncover new things that would evolve health recommendations. And as a population that was a lot more used to health messages that were more static, something easy like eat less calories, move more, this was a little jarring and hard for them. And then also, when you're looking at the many channels where people can now access information, like old video clips, screenshots of old tweets, this fed into a new dynamic where old messages were used to push back on newer messages. This could have been done inadvertently, where people were, maybe just questioning things, or it could be done more maliciously to discredit new science and recommendations. And then I think another thing that was a real challenge was sometimes the messages were driven by new revelations or outcomes in urban or suburban areas as new variants emerged or disease changes were happening. And often that wasn't the case across, in particular when you're thinking about the US, the whole country. So the national message was changing quicker than the local situation and the local reality. So that was hard for people to grasp these changes that were coming at them. And of course, it wasn't just messaging. There was a lot of other factors that were going on, particularly as the pandemic evolved. COVID burnout, lots of messages from lots of messengers who had competing priorities and goals in mind. other stressors that came with living with a long pandemic, political divide and cultural wars, all of which could take many, many panel discussions to unfurl into themselves. But on the whole, I think we can all agree that all of this combined really led to confusion, misinformation, and in some cases disinformation, which again is a whole other panel discussion, and non-compliance with health recommendations. So as health professionals who want to communicate in an increasingly complex world where we are and will face other challenges like this, what can we do? And I will say that as I talk through some of these ideas, some of these things did happen, particularly over the course of the pandemic, and some more savvy communicators and different voices did do this. But I think it's worth keeping in mind because there's a lot of complex health challenges and other challenges out there that are coming down the pike that we can all learn from when it comes to this. So first, I would say we want to understand what makes a sticky message, and we want to get our sticky messages out there. We want to ensure that, we're in a unique place now with COVID. I think for people who understand and were able to grasp the evolution of the message throughout COVID, it actually sets them up for an understanding of evolved health messages and complex challenges in the future. But that's not everyone. So we also have to recognize we'll have to still educate people on the fact that messages can evolve in relation to the same health challenge. Misinformation is not going anywhere. I know one of the panelists who's coming later is going to talk about that a little bit later. So I think that it's something that we just naturally need to be monitoring for, finding ways to quickly react to, and then engaging partners to help. And those partners can be diverse as different voices that we want out there, to working with platforms to actually, flag or take off misinformation as it's happening and quicker in real time before it can spread. And then I think we really need to, like all good health campaigns do, is really use a wide range of trusted voices to get people the messages that they want to hear from the people they care about and they trust. And where possible, localize that message so that it's understood that what's happening in the community is really what we're talking to them about, to make it work for them. And then finally, expect the unexpected and problem solve when that happens, because the challenges of today and the past 2.5 years will be there and repeated in some ways, but particularly with the rate of communications and the different channels that people get it, they're only going to get different, and we just have to be, humble and prepared to address them. So thanks everyone for the time, and look forward to the discussion later.
Thank you, Rosanna. Those excellent points. And there are lots of questions coming in already. So please keep your questions coming, and we will get to them as soon as we hear from all of our speakers. So next, I'd like to turn it over to Ashley King.
Thank you, Lisa, and thank you everyone for this opportunity, and BUSPH, my alma mater. So as Lisa mentioned, I am a health communication manager at Communicate Health. And so here I am literally living out my wildest dreams and creating health campaigns and developing far-reaching health communication programs and materials like websites and videos and social media. And I'm excited to spend my time talking about something that may be a little bit different for this group, and that's empathy. I've been super passionate about using health communications as a way to start meaningful conversations with people and with communities about health. But I've learned along the way that if you bring empathy to the table, you can truly elevate your campaign. Why? Because empathy fosters trust. It encourages connections. It helps you to look at the facts a little bit differently to find solutions to your audience. And it acknowledges the unique differences within and identities of our audiences, because we all know that science has not been always a beacon of safety and hope for every group in this country. And most importantly, as we're still grappling with and recovering from the evolution of health communication because of COVID, I think that it's super important that we think about empathy and use it as a way to transform our conversations so that we're not talking at our audience, but we're talking with them, and that leads to the change. So I'm here to talk to future health communicators and teachers of future health communicators. I just want to encourage everyone to think about empathy a little bit differently. And I think there's a few ways that we can start. I would say that looks like listening, applying, relating, and educating. So first, Listen. This is something that we do every day, but really dig in, actively listen, engage, ask questions, and seek to understand concerns, preferences, and unique experiences of our audience. Also, be intentional about your campaign planning to create opportunities to listen. At Communicate Health, which is where I currently work, we follow a human-centered design, which is a creative approach that believes that problem solving starts with people and it ends with new solutions. And we ensure that we start our campaigns and any activities that we're doing with activities like formative research, literature reviews, focus groups, surveys, and work groups. We just really think that this philosophy allows us to start our process by listening to ensure that the voices that are being heard will be impacted most by this work and will influence the work. So next, after you've listened, I think you also have to apply it. Maybe you're already listening to your audiences and you have the amazingly big reports to show it, but it's not impactful if you don't ever really apply what you've learned and you've heard from the community. So you must use what you heard as an anchor that grounds your work and the needs that have to happen in the community that you're serving. You never know, those words and insights could be the key to understanding why that huge campaign that you used every tool in the health communication toolkit maybe just didn't quite meet the mark. I will share that during my experiences working with local government, we often found ourselves wondering, why aren't people using our resources? We spent hours on this, we planned this event and we spent months doing it, but for some reason, it just didn't click. And why? Even though we used all of the health communication best practices. And I think it's because we heard what they needed, but we didn't really apply it in our planning. So sure, we spent time listening, but we planned it at the wrong place. For example, we wanted to engage teens, but we put it on the wrong platform. Or maybe it was the wrong time of day. We wanted to schedule events for them, but it was corresponding with either school-related events that they really were passionate about. Maybe we could have merged our forces and came to their events as opposed to trying to create something new for them. Another thing is we just wasn't clear enough. We did a great job explaining why behaviors weren't right and what to do next, but we didn't really tell them, okay, well, how can I quit this behavior? What are some small steps that I can take? And so that left our audience a little confused. I think that these experiences and then others also have just reinforced to me that we must listen to our audience, but also we need to make sure that we're translating that into actual action and that we're incorporating it into our planning and implementation processes. So, okay, now you've listened, you've applied your learning, we're done. Nope, we are not done. We must continue to relate to our audience. As health communicators, I completely understand that we have a really hard job of trying to educate the community on topics that vary in levels of difficulty. And then when you add in that lens of COVID, it gets even more difficult. As we know, health information has been just evolving, honestly, and with so many concerns about miscommunication, which I know our panelists just discussed, it's become even more challenging. But I just want everyone to pause and think, who has a harder job? I think it's our audience. They're trying to understand it all, and they may not have that public health background to really aid their understanding. We have to find ways to relate to our audience and remember that health communication is personal and emotional in some cases. Understanding health information can be complicated by itself, but then when you have anxiety and fear in the mix, it can make it even harder for our audience. This is why I encourage you to think about empathy and think about the words that you're using. So there's a few ways we can do this. Maybe it's choosing more familiar words. I know in the field, sometimes we throw around jargon that is common to us, but it's not common for our audience. Plain language allows you to clearly communicate messages and use it in ways that allows people to really understand it. And I know that we love concise writing, but sometimes it's okay to write a little bit extra words just to make sure that people really understand and that we're clear. Also, inclusive language. Remember to be culturally aware and sensitive of how you reference your audience. For example, your audience is not a target. We're not trying to hit them. They're a priority and we want to uplift and engage them. Small changes can go a very long way. Another way to be inclusive in your language is to avoid overly relying on stereotypes and labels to guide your language. Seek to know your audience and acknowledge the barriers that may impact their ability to do certain behaviors. For example, your non-compliant patient may not be lazy, but their actions are a consequence to unfair challenges in our societal structure or limitations as it relates to cost, access, time, or transportation. Beware of your possible condemning tone and language based in stereotypes, because you may send a powerful message, but not the message you were hoping to send. So I hope that you can see that writing inclusively can be challenging, but it's also worth it because it'll make sure that your audience feels seen and heard. And lastly, I want us to remember our duty to educate. At the root of health communications is the desire to provide learning opportunities to our audience. We create in order to engage, in order to inform, explain, and to highlight something new that can literally change lives. And to do that, we can use empathy to think about our approach. We can put ourselves in other people's shoes to think about questions they may have and make sure that we're answering that in our materials. We can offer to be a credible source, given there's so many concerns about misinformation out there, so that our audience knows that the facts that we're giving them are things that they can hold tried and true. And then next, provide clear next steps. We don't want to just throw out ideas. We want to give them the tools that they would need so that they can actually make that next step towards a healthier life. So I hope that you all can bring a commitment to empathy into your classrooms, into your companies, and find ways to listen, to apply, relate, and to educate our audiences. And while many of these steps are seemingly small and probably things that you're already doing or have thought to do, I just want to stress that it can really go a long way in building trust, promoting inclusivity, and elevating your campaigns. So before I close, I'd love to just leave you with one statement. There are other people on the other side of your words, you write, and you have the power to change your life. I thank you all for this time.
Thank you, Ashley. Excellent points. And thank you to all of the engaged participants for sharing more resources. So we're all writing furiously, I think, all of these things. We will have a recording of the session, so don't worry. You'll have a chance to digest it even more. Thank you for that. Next, I will turn it over to Sarah McKenzie.
Well, thank you so much. It's certainly an honor and a privilege to be on this panel. And I'm quite excited to be part of this group and to address some of the questions I've been seeing scrolling by. I titled my talk, Writing for Public Health Strategies for Teaching Writing. It is the title of the article that Jen so kindly referenced earlier. I wanted to start by sharing my story because writing is really storytelling, and it comes out of a long tradition of storytelling, both oral and the written word. We've just prioritized, at least in the recent past, the written word. My story with writing formally began in my undergraduate training. I was at the University of Iowa pre-med, studying biology, definitely taking all the science courses. But the University of Iowa also has a very well-known writing program. And so while taking science courses, I was also taking creative writing and poetry. And I didn't really realize how that was influencing me as a learner at that time. As I progressed through my career, practicing as a family and adolescent medicine physician, I incorporated writing clinical notes, communications with colleagues. I started working more in the community. I also came back 10 years later to do an MPH at the University of Washington and had that really harsh reality of writing in a completely new way. And so can totally connect with what Jen shared about that life course perspective. My interest in thinking about how we teach writing really began as I was working at the University of Washington in developing the undergraduate public health global health program. And it was through that work that I began to think about how we learn writing ourselves and how we can best start to work with others to develop those skills. Let me move to my next slide. So I think it's always important to start with why is it important? There's so many reasons. These speakers thus far have already shared really important reasons why communication is important. We have in public health as a discipline, we have really diverse messages that we are delivering to really diverse audiences for really diverse purposes. So that's super complex to begin, right? And so we better be a little intentional about how we're doing this, how we're structuring it. We also have learners in our programs that come, hopefully, from really different lived experiences. That is our goal, to train, and it's actually our assigned task in curriculum development in schools of public health, to train a diverse workforce. And that means we're intentionally recruiting and developing at the undergrad, the graduate, at the postgraduate continuing education level. We're recruiting learners who've come from tremendously different backgrounds so they can have that empathy, so they can communicate with different audiences, so they can take different messages to different groups, whether that is working with in writing grants to get funding to work in certain areas, or working in community or rural areas, outreach for those COVID-19 consistent messaging and trying to counter some of the misinformation and disinformation. So I think this second bullet is really critical, that if our goal is to work with students from different backgrounds, we have to be intentional in acknowledging the types of writing that we're asking them to do and how it connects, having empathy for how it connects with their lived experience. I hear frequently, and I'm sure you hear frequently, students can't write. I don't even know where to go with that as a statement, because yes, they can probably tweet really well, or they can probably write video scripts really well, or they can write in other ways that I have no experience in. I write in certain ways that I've had experience in, that I've learned and developed skills in. So I think we have to have that empathy, and we have to think intentionally. We have to call out the societal positioning of writing. It is a main form of communication. It has changed to tweets and mass media, but writing in all these different ways remains and will likely always be important. If you're developing a curricula, you also might want to look at the Council of Education for Public Health Competencies. They have specifically called out and addressed communication, written, technical, professional writing, mass media, and we could spend hours coming up with lots of other reasons why critical. So we often in writing, or as I dove into this, I started to understand that we call these different styles of writing genres. They have different rules or expectations or criteria that we attach. At the University of Washington, we surveyed our faculty and said, well, what are the public health discipline specific genres of writing? And we came up with a list that Jen in her book has expanded on, and I've heard even a few already that we could add to this. But it was really fun, and it started to get faculty to think differently. One of my favorite experiences was a colleague in our school-wide curriculum committee meeting where we were talking, and he said, I'm very comfortable with grant writing and scientific article writing. I've never written an op-ed, and that kind of scares me. I wouldn't know where to start. And I was super excited 10 months later to open the Seattle Times and see his op-ed that he wrote with a student. These conversations challenge all of us, no matter where we are in that life course, and it makes it intentional to think about the types of things we are reading and the types of things we are writing. So how do we integrate it? Well, there's these other concepts I'm going to throw out there so that you can do a lit review or a Google search or whatever source you like to get your information. Writing in the disciplines is this idea that each discipline has types or structures to writing that is specific to the discipline. So when you come from your PhD in literature and English and you come to public health, it's completely different, and it frazzles and jumbles your thinking because you're learning new content and new writing, and you have to figure out how to put it together. So there's this idea that writing can help you with learning. I know I wrote notes for my thoughts for this talk. It helped what seemed brilliant in my mind. When I put it to paper, I'm like, oh my gosh, this doesn't flow, and I'm confused. We can assign tasks that are quick writes, that are low stakes writing. That's writing to learn. It helps us organize. That could be journaling, self-reflecting about your progress. And then there's what we call learning to write in the discipline. Our students may have learned sentence structure and verbs and things, but in the discipline, to write a grant has specific components to it. It has content that needs to be included. There are things that are valued. There's structure, there's action. Those are types of formats that may not be included in other types of writing, such as the tweet or the blog that maybe our students have worked with before. So that learning to write, that assigning specific genres, students have to, it's very hard if we're asking them to grapple with new content and new structure to the writing. So we can break it down and think about how to introduce and teach content and structure. And that brings us to, again, Jen's book. Here's the reference. Someone asked for that again. She applies something we're familiar, social ecologic model, to writing. Brilliant. I love the social ecologic model. It recognizes it takes a village. It's not just one individual or one course that can teach writing to our students. Writing has to happen at the individual level, the interpersonal level, the community level, and the systemic structure within both the department, the school, the university, our broader institutions. Reach out across, know what resources you have on campus. I continue to teach a freshman personal and public health course. It's partnered with a required freshman writing composition course. It's a brilliant way that I'm teaching content, and in their writing comp, they're getting to do writing, their required writing in an area that they're excited and interested in. University of Washington has a writing resource center. We work with them both. They come to help with faculty development, but also if we identify a student that's struggling, like Jen mentioned earlier, it's not our job to totally be responsible to teach them to write. We can help if we recognize somebody maybe is struggling either with structural writing or discipline specific. We can help by referring them to other resources. And then that also includes our broader institutions. The ASPPH has put a lot of interest and emphasis, teaches regular workshops to help in faculty development or grad student development of writing. Public Health Reports has a specific department on writing. I've tagged a few of the articles that you can read. You can also become part of this community. It is a broader community of people that are engaged with thinking about how we best teach these skills. And I'm going to end there and pass on to the next. Thank you.
Thank you, Sarah. Excellent tips. And for those of you who keep writing, can we get the slides and all the resources? We're collating them as we speak in real time. So all of these will be shared. Thank you so much for that. Our next speaker is Xiaoli Nan.
All right, I believe I've shared my slides. Thank you, Lisa. It's an honor to be here today. So I'm going to talk a little bit about public health communication. So as we go through the pandemic, and there is a lot to be learned about effective public health communication. And I'll briefly talk about some of the missteps in COVID communication and how we can do better in the future. Right. So, well, I think we all know the pandemic is enormous global challenge, right? But it is also manageable problem because we know what the solutions are, and we knew very early on in the pandemic that social distancing, wearing masks, can reduce the risk of infection, and vaccines were invented within weeks that could not only reduce the risk of infection but also lower the chance of severe illness from COVID. So if these simple protective behaviors had been adopted by the public on a broad scale, the pandemic would have been under control, right? I mean, we can only dream about that, but of course, this is not what happened, at least not in the US. Throughout the course of the pandemic, there was active resistance to these behavioral guidelines, which has resulted in many preventable deaths and prolonged the pandemic. So could we have communicated more effectively to the public to mitigate the impact of the pandemic? I think so. We could have communicated better. And I'll highlight just 3 possible communication missteps that we took during this pandemic. So the first misstep, I think, might be an over-reliance on fact-based as opposed to value-based messaging. During the pandemic and public health communication about COVID often, as you can see, focus on scientific factual claims. And these messages would suggest that, COVID is, contagious and showing how it spreads among unprotected individuals, or they will show that the seriousness of the disease, citing hospitalization rates, perhaps. And after the vaccine arrived, the messages would emphasize the effectiveness and safety of vaccines. Now, communicating these fact-based scientific claims is an important strategy, of course, and many publics may be persuaded by such messages. But studies have increasingly shown that vaccination and other pandemic mitigation behaviors are also driven by moral values. Right? It's not about what I know or don't know. It's more about what is right or wrong, right? So values like freedom, do I want to feel free? Do I want to have liberty or sanctity? The idea that I want to keep my body pure. The idea of purity as a value. So a lot of these behaviors are driven by values. They are not really about what kind of knowledge we have about the pandemic or about these behaviors. So what does that mean? So we wanted to kind of look into the moral roots of COVID-19 vaccination. So my research group at the University of Maryland, we conducted an online survey in February 2021 with about 1,500 Black American adults who had not received the COVID vaccine at the time. We wanted to focus on Black Americans in our study because we know that people of color were disproportionately harmed by the pandemic. So they are a really important population to look into. So in the survey, we asked a series of questions that measure individuals' moral values. Here, as you can see on the screen, there are 6 moral values: caring for others, fairness, loyalty, respecting authority, purity or sanctity, and liberty. And we took these measures from the work of John Haidt and Jesse Graham, and their really influential work on moral foundations theory. So our results show that 4 out of the 6 moral values strongly predicted vaccination intentions. And these are effects that emerge after we control for important demographic variables. And stronger beliefs in the moral values of care and loyalty were associated with greater odds of wanting to get vaccinated, whereas stronger beliefs in purity and liberty significantly reduce the odds of wanting to get vaccinated. So these results really shows that moral values play a very important role in making vaccination decisions. But in our public health communication about COVID vaccines, we really just talk about, oh, the vaccines are effective, they're safe, just go and get it. But we really address these moral values or the moral roots of these behaviors in terms of why people choose to vaccinate or not. So we need to look into those values more and write about values in our communication with the public. Now, the second misstep, I think, in COVID public health communication, I think it might be the use of messengers that are not necessarily trusted by individuals whose behavior need to be changed the most. Mainly, as we know, Republicans and conservatives, as surveys after surveys show that they are most hesitant about getting vaccinated and also wearing masks and other things. So as health communicators, we sometimes assume that communication from public health agencies and officials will be and ought to be taken seriously. And this might be the case for many Americans. I'm not saying that people are not trusting these entities, but the pandemic has really exposed or exacerbated the erosion of trust in public health institutions and officials, and especially among our conservative Americans. So this is a recent survey conducted by the Edinburgh Public Policy Center that shows that public trust in health agencies officials is sharply divided along the partisan line. So overall, trust is very high among Democrats, but as you can see, it's pretty low among Republicans and conservatives. As you can see from the graph, I think trust in Dr. Fauci hovers around like 30%, in that particular population. So what does all mean? Now, as an illustration of the importance of trusted messengers in public health communication, a recent study conducted by Pink et al. So they presented a group of Republicans with a video, a Biden video or Trump video endorsing COVID vaccines. And what they found was really telling. So among unvaccinated Republicans who watched the Trump video, they reported significantly higher vaccination intention than those in the Biden condition or the neutral control condition. And there was also a backlash effect against the Biden endorsement. So Republicans who watched the Biden video reported that they would be significantly less likely to encourage others to vaccinate and had more negative attitudes toward the vaccine compared to those in the neutral condition. So using trusted messengers, to be more specific, in-group messengers, people that you feel like is part of your group, or part of your social identity, is a really important consideration for future public health communication. Trust in source is a very important variable in communication process, and I'm a communications researcher. But it's very interesting to see that it is not nearly getting as much attention as it should be in health communication in the real world, right? So we shoot out message from CDC, FDA, Dr. Fauci. We thought this is it. This is the most authoritative, the most trustworthy messages, but it may not work, for maybe 1/3 of the country. So we should really pay a lot more attention to source or messengers in future public health communication. And finally, misinformation is something on everybody's mind. And I think a possible communication misstep is, I think, our over-reliance on fact-checking as a way of fighting misinformation. So fact-checking, telling people, oh, what you just saw is not correct. Here's the correct information. Now, there's no doubt that misinformation is a very insignificant public health threat. But what I want to point out is that people are susceptible to misinformation, or they believe misinformation for all sorts of reasons, right? So one of the reasons being that they don't have the knowledge, right? They don't have the facts. If that's the case, fact checking, general correction may really work because people just don't know. But I think more often than not, people believe in misinformation, not because they don't know the facts, but for other reasons, right? So, so my research group at Maryland, we looked into the reasons why people believe in misinformation, and we conducted a very comprehensive sort of systematic review. We found that there are basically 4 kinds of reasons why people buy into misinformation. And we recommend for each reason, or when each driving force is the reason that people believe in misinformation, we should use a specific kind of intervention. So it's more of a targeted intervention. So for instance, if a lack of ability to reason accurately, which lead to a lack of knowledge or skill into decipher information. If the lack of ability to reason accurately is to blame, then we can use targeted interventions like education, literacy training, pre-bunking, fact-checking, or general correction. And these are very popular interventions. I think these are being done and being utilized quite a lot. But as I said, that's not the only reason. It could be that people buy into misinformation just because they're really lazy. They don't have the motivation to reason accurately or process information in depth, right? So if that's the driving force, we could use interventions like using the accuracy nudges, basically just reminding people, hey, there's a lot of misinformation out there, so be careful. Or we could try to, in general, try to increase trust in science, right? So that trust can sort of serve as a heuristic for individuals to sort out this information from accurate scientific information. And then there are cases where people just rely on their priors, or what's called directionally motivated reasoning, in that, I believe in this information because it's consistent with what I already know about how the world works, right? So if that's the case, we should use interventions that focus on reframe the facts and policies in a way just to make them feel like they're in line with people's prior beliefs and thoughts. So that's how we address misinformation issue in that particular scenario. And finally, sometimes people believe misinformation not because of any of the reasons I've said, just because they have a desire to protect their personal or group identities. Right. So if that's the case, we could use interventions, one of them being called self-affirmation, or we can try to change people's perceived group norms, or ultimately we need to use in-group messengers in those cases to try to talk people out of the misperception. So I think the key idea here is that we need to use more of targeted interventions to deal with misinformation. So fact checking is not going to solve all the problems. So in conclusion, going forward, I think we need to try to understand the moral roots of health behaviors. Okay, and knowing that health behaviors are not simply based on knowledge or whether or not you know the facts. Sometimes it's just, is that right or wrong for me to do this? So looking into the moral values. We should be using trusted or in-group messengers a whole lot than we have done so far, and fighting misinformation using a targeted approach. These are the 3 I think, take-home messages and, what we could learn from the pandemic. That's the end of my presentation.
Thank you so much. It's so important to understand all of these reasons why people understand or don't understand messaging. It'll help us in creating better messages. So our final speaker is Kazasomaya Jula Viswanath. So I will turn it over to you.
Wonderful. Good afternoon. Dean Sullivan, let me thank you, and also Dean Kelly and the rest of the BU team. I'm here sitting in India. It's late in the night. It's a wedding season. There's a band going around in my hotel room. So that's the reason, hopefully, it won't be too loud. So hopefully you can still hear me. I think what a distinguished panel. I think what a wonderful fount of ideas that have been emerging, as a part of this conversation, given how fundamentally critical and foundational is writing to public health and articulating arguments and ideas. The way we approach this is from a philosophical perspective, and I think from a pedagogical perspective, I look at how do I teach health communications. So what really drives my pedagogical philosophy in teaching health communication. If you look at students, if you talk to students, in fact, if it's a large range of people, they approach health communication as something that can be done with intuition, or with trial and error, or with experience. And my challenge is that these are all very good. I think trial and error matters, so you learn a lot over time. Intuition is pretty critical, pretty important, no question. Experience matters. But being the fact that we are in public health sciences, and that how do we really get our practices to be informed by evidence, is a real challenge, I think, in working with students. And I think, whatever we try to do, especially, COVID has been invoked a few times, but it's just not COVID. Everything we do in public health is evidence-based, right? We compile that evidence base. And the question then is what we are doing in writing and training our students. But generally, as a practitioners of public health, we try to translate that evidence base in a varieties of ways to inform practice and policy, I think. And so that's what is the challenge I'm trying to meet as I train my students in health communication. So it is basically then, three perspectives guide that work, or that pedagogical approach I take. One is what I call as a problem-based perspective, problem-based, so I think it is nice, as most of us are academics. It's nice to come from a theoretical perspective. We are very comfortable with it and we can do it. I think, but our students, when they come in with they come into public health with inspiration because they have encountered things in their lives and they want to come and solve that problem, whatever it is. They come with that idealistic notion. And so I think introducing them to the variety of public health problems and then introducing evidence for how to address those public health problems is what I try to do. And I think that's one is a problem-based perspective. Second is practice-based evidence. I think at the end of the day, I think you got to really have that interaction between what we do in academy as research and practice. I think this is not my phrase. Larry Green, the famous public health practitioner and scholar, used this phrase, practice-based evidence. What do we learn from our partners in the community, from our practitioners who are doing it day to day, and how do we bring it back into our research settings, our pedagogical settings, that kind of a practice-based evidence. And last perspective is equity informs everything I do and everything I teach. It centers, it anchors, it is the foundation to what I teach. Given everything that is happening in our country or globally, I don't know how we can ignore equity and equity-centered pedagogy in anything we do, I think, right? And I mean, that's how we do it. So whatever topic we choose, whether it is the complexity of the information environment that has come out, how complicated the information environment is, or who produces health information, with production of health information. I think often we are under the illusion that we are the people who produce health information, but there is an entire group of people who are being paid a lot of money or spending a lot of money to produce quote unquote health and risk information, completely counter to what we believe in, or whether it's information, misinformation, or disinformation, or the common impression we have about social media, or social networks. And last, I also, as I teach these things, try to broaden the definition of health information or health itself. Health, I think, I have been going back to the classic WHO definition from going back to 1948. Health is not merely an absence of disease, but a complete state of well-being, physical, mental, and social, which we often forget. So how do I communicate all of them? This kind of a more broader definition of health as we teach in public health, our public health communications, I think. So, as a part of the writing process, somebody used the phrase, which I loved it, it's writing to learn, learn these perspectives. That's what I try to achieve. So I use policy briefs and practice briefs. Policy briefs because they have to communicate with policymakers in translating evidence. There are varieties of reasons why policymakers may adopt evidence or may not adopt evidence, right? We know that. And the question, but we write, we do policy briefings, I think, and a part of that is, to write these briefs. Practice briefs. How do we work and engage with our community partners? So these practice briefs become very important. Campaign strategies is another tool I use for writing. It's not just academic writing a term paper, but really, how do you write a strategic communication campaign strategic tool, to communicate with people, and short analytical pieces, engaging in a colloquy with other people. How do you do that? That kind of a discursive writing, I think, it's very critical. That's what we do. Last, I think, I will stop after this. I really push for what I call as an inclusive science, understanding that inclusive science. What I mean by that, we invoke often like a mantra, community-based participatory research. I don't know what it means. It's a goal. It's something we strive for, but there is still a fundamental asymmetry between academy and practice, academy and community. Being sensitive to that and being open, as somebody talked about listening, exactly. Why do you listen? How do you listen? Right, that kind of an inclusive science means, using community-based participatory research, but also engagement science, really being with the community, bringing them to the table, and having our students work with the community partners, is again a critical pedagogical tool, I think. So as we go forward, some of these practices seem to work very well, and I constantly assess and evaluate which ones work well, which ones don't. Again, learning and listening from my students, they have fantastic ideas of what works and what doesn't work, and trying to incorporate and make those amendments and changes in my way of how I teach these things and how I incorporate writing. So let me stop here. I've been going on and on, but thank you for the opportunity.
Thank you all so much. You probably haven't had the opportunity to see the comments coming in the chat, but the audience is so appreciative of your expertise, is learning a lot. So there's clearly a lot to talk about here. So we have a few minutes for questions. I'm going to throw a couple out and see if any of you can respond. So the first is, first I want to say that we have in the audience faculty, practitioners, students, but hearing all of you, I think each of us are all of the above. And so I want you to think of this question, with any individual in mind. For those of us who don't see ourselves as writing mentors, how do we become sensitive, empathetic mentors? And how do we build confidence to provide good mentorship? People are looking for some concrete skills and suggestions. Go ahead, Jen.
So I think I would go to Ashley's excellent talk, that it's really all about empathy. And I think most of us as professors, we have that empathy. Sometimes our frustration about the writing that gets handed to us, often the first draft, because people don't realize that they should have started early and they should have revised and all of that. That's really key. And, I feel like I hear a lot from colleagues that, I wasn't trained to teach people how to write. I don't know how to do this. And I feel like that shouldn't be a barrier, because it's really about listening and helping people see where what they're saying doesn't make a whole lot of sense, and helping them, just taking the time to talk to them and say, okay, what did you mean here? And the problem, of course, is that is very time consuming. When I taught freshman writing, we had students turn in papers every week, and then we met with every one of them for a half hour every week and talked through their papers and had them read them out loud. And as I think a lot of us have talked about, our students are starting all over again in some ways when they get here. They're building on what they did as undergrads or as high school students, but having that time to give to them is key. And that's where the institutional kind of shift needs to come in, that we really need to provide our professors from an institutional perspective with the time and the and other resources and the ability to say, you know what, I think you would really benefit from being able to go and talk to a peer coach. And it might not be perfect advice that you're getting, but it's some kind of feedback, and that's useful. And that's, I think, what helps people. But I will stop rambling and let somebody else talk.
One thing I was going to add to that is, I think that this concept that we have a social ecologic model. It's not just one faculty who has to be the mentor to fix the problem or the challenge that you're seeing in the writing. So if we step back and we integrate writing and the importance of writing and the structuring and the scaffolding of the development of writing skills, integrating that evidence-based practice and doing quick writes and commenting on, or being clear, are we asking for a student to understand the content and we're trying to see if they're grappling with content? Or are we intentionally asking them to try to structure content in a particular way, and we're seeing challenges with the structure? And then again, to echo Jen, and really what Ashley said, the feedback and all motivational interviewing revolves around, I'm not here to fix it. I'm here to help the student or the learner identify how it doesn't quite align with what I was asking if I'm assigning something, and helping them determine what the steps are, what they want to work on fixing. Because I can correct it and I can redline. We've all had papers redlined. The data shows if you add red circles, it just goes in the pile. People don't read it. If you identify in a paragraph that there's 3 structural problems and have the student find them, they're much more able to then address that in future learning. So I think it starts with, we don't have to be the only mentor, and giving permission that you don't have to be the only one, and you don't have to be a perfect writer. None of us are.
That's reassuring. Thank you. Rosanna, were you going to jump in?
Yeah, the only thing I wanted to say is I don't review students' writing, but I review a lot of other professionals' writing. And I think that the point that Sarah had earlier about how there's a lot of different types of writing and different people are good at different types of writing is something that I often lean on when supporting my colleagues when maybe something hasn't hit the mark, but sometimes reframing something, if it could be written as a tweet or written as a video script, and thinking about how to then morph back to the type of work at hand, sometimes can just get people out of a sense of being maybe criticized in that current writing, but think about how they can use skills in another type of writing and redirect it for the task at hand.
So another comment came up, how do you strike the right balance between feedback, criticism, and stifling creativity? And you sort of started on that, Rosanna, there.
I had a thought about that, and I think I was kind of noodling on it, for lack of a better word, but I love the teasing out of it's the structure, but it's also the words. And I think a lot of times, maybe through shared learning and just exposure, we can kind of come to some conclusions about what are ways that you can do it. Because I agree, if everyone's following the same rubric, then we're all just kind of writing the same thing. But we want you to bring yourself to the space. We want those unique experiences. We want to hear how you thought we should approach this topic. And I think that there's beauty in maybe sharing it. Like when I heard the topic of adolescent health, this is where my mind went, and this is how I thought to structure it. And maybe it's teasing out like maybe the words versus maybe strategy wise, this isn't quite the best approach, but allowing people to hear how other people or others, their peers, were able to approach things could be really interesting, just to provide that coaching. And like you said, it's not just the responsibility of teachers, it can be learning from all of the places, and even learning from what's not working. Maybe looking at things and dissecting it together to determine, how can we have done this better? What do you think we could have done better?
Great, thank you. Several of you talked about the right messenger, localized, trusted messengers. How do we become those people?
I'm happy to jump in here. I mean, I think that in some cases it's great if you are that person and if you happen to fit that bill, but I think we have to realize that in many cases we can't be the messenger all the time. For certain instances we can, but oftentimes, and that's, I think, a lot of the value of the collaboration that comes on public health campaigns or any sort of health campaigns is, that is really incumbent on the people who are developing that, is to, again, look at who your audience is, see where they're going for information, see who they're trusting for information. And, sometimes that from what worked or worked in a different campaign, but oftentimes, as we heard from Ashley, you don't know that until you actually talk to those audiences and, uncovering that information from them and figuring out how to help them, help yourself, help them.
Thank you.
Yeah, let me jump into, I also saw a lot of questions about trust. How do we build trust? Trust in public health and science institutions. I think that's one of the biggest threats to our society, is the eroding trust in these institutions, which are supposed to provide objective facts and scientific, evidence. Building trust has to be a long process, right? And losing trust was also a long process, and that has happened over the years. And we just saw during the pandemic, everything kind of broke down a little bit. So in my mind, I think the most important step as a scientific community and a public health community to rebuild trust with the public is to depoliticize our institutions, or stay away from politics intentionally. I'm not saying that is necessarily the right thing to do. Sometimes you stand for science, and sometimes you stand for science. We believe in science and the scientific process, and there are people and fractions of our society who are more aligned with our values, right? But I think it's very risky for us as public health and science institutions to make like a public statement. We stand with this group, or we stand with that group, because we both believe in science. I think we can hold on to our values without attaching ourselves to any specific group in the society. Because if we attach ourselves and our identity to a certain group, and then we alienate the other groups. So I think that is perhaps the most important thing we need to do as scientific institution, is to depoliticize our institution and really decouple the scientific process from the political process. And as Rosanna mentioned, maybe we're just not the right messengers, right? We can't be the right messengers. We have to find the right messengers. And, we can go for influencers, social media influencers, even, there are people that we should actively reach out to those local voices. The best thing we can do, if in the event that we're not trusted, we should reach out to potential trusted sources. I think we need to really connect with those local voices. And our persuasion happens between us and the influencers instead of between us and the public. So if we can get a few influencers on board, they're going to be much more powerful as we are as messengers to the broader, society and community. So that's something we can work on. And finally, I think there are studies really suggesting that transparency does increase trust. It may, in the short term, increase maybe, vaccine hesitancy if you tell people all the risks and everything. But in the long run, being transparent in communication is something we should invest in, is something we can do that just to build a long-term trust. So those are the steps I would take.
Thank you. Does anybody else want to comment on that one?
Yeah, just a couple of points. I think trust is not built overnight, number one. I think, it's something that's developed over a long period of time. Number two, we should also look at the data. The data are not that pessimistic. If you look at the data, yes, there is a slow, steady erosion of trust, but it's still pretty good, so it's pretty high. I think, again, we have to be data driven in these things, right? I think there is a general feeling that trust is somehow collapsing, but that's not completely accurate. It is certainly questionable within certain groups. And third, I think, expertise is diffused, right? It's just not within the technical scientific realm. Maybe there is a technical information expertise within the scientists, but within the community, there is a tremendous amount of expertise on how to engage and relate to members of the community itself, I think. So I think doing that kind of a stakeholder mapping and working with the community right from the beginning, having the right platforms to engage the community members right from the beginning, right? Not bring them in later, but to have them at the table as you're defining the problem can go a long way, I think, it's not about identifying trusted messengers. They should be right there from the beginning with us to communicate these things.
Well, thank you all so much from all of the activity in the Q&A and in the chat. There's so much interest in this and so much appreciation for all of your expertise. So thank you so much for being here. I certainly learned a lot from all of you, and it sounds like we have enough interest to do this again and very soon. So you may be hearing from us again. I'll turn it over to Dean Galea to close the session.
Well, let me echo thanks from Dean Sullivan, and thanks to all the panelists and everybody in the audience. I often keep thinking that we are in public health in the sort of proverbial worst of times and best of times. I mean, it's the worst of times because we all recognize we're going through some really difficult moments as a world. I mean, difficult moments on social forces that matter so much to public health, from all the way to pandemic. The best of times because I feel like this moment is bringing forward ideas and engagements in public health that are really more interesting, more forward-looking, and more innovative than any I've seen in decades, which fills me with hope. So when I hear this conversation today, and I hear the Q&A from the audience, I learned tremendously, and B, I'm left filled with hope. So despite the challenges that we're facing, I feel like if we can extract from the moment learnings like the ones today, the world will be heading in the right direction. So I want to say thank you. Thank you to all of you for everything you do. Thank you to all our panelists. Thank you to Dean Sullivan, and thank you to the audience for participating in this. Everybody, thank you for what you do for health. I hope everybody enjoys the beginning of summer. Take good care, everybody.